I'm going to share with you our experience in screening for screening for carotid stenosis using MR. And on many of our cases, we also have Doppler and conventional angiographic studies for comparison. Now, our protocol for carotid MRA is, I think, somewhat longer than those proposed by other people, in that it takes about 35 minutes in the magnet, and it consists of 3 sequences. Now, in my last talk, I emphasized the differences in capabilities between the 2D time-of-flight method and the 3D time-of-flight method. So our protocol includes both 2D and 3D methods. Now, there's a lot of debate among investigators as to whether we should be looking at carotids with just 2D or just 3D. And I think the answer is you really need to do both because there will definitely be systematic artifacts if you choose simply one of the 2 methods. We do a 2D time of flight first. It's done fairly coarsely, fairly quickly. And the purpose of this really is to discover where the vessels lie, to find out which vessels are patent, and most importantly, to differentiate critical stenosis from occlusion. Because you know with the 3D time-of-flight method, you may not be able to see the slow-flowing vessel beyond a stenosis. Then we do a sagittal, and we do this 3D, and this allows us to see the carotid over a very long distance. Then optionally, we will do a transverse 3D acquisition, and that's usually centered at the bifurcation because that's where the action is. But it may be somewhere else if we suspect a lesion at another location. Now, our 2D sequential is done, again, a little bit different from what some other people are doing. Now, I know a lot of people are using the so-called walking saturation band or traveling saturation band, in which you have a superior pre-saturation to eliminate the jugular signal. We remove the sat band when we're doing our 2Ds, so we see both carotid and jugular on our image. And the reason why we do that is because of the relatively common occurrence of reciprocal flow in vessels. We don't want to miss a vessel simply because the blood is going down the neck instead of up the neck. Now, in this case, for example, we see the vertebral artery is missing on the left side. We see a large musculoskeletal branch. And as we look through our slices, we see reconstitution of the vertebral, and then more distally, a large vertebral artery. Now, you can use 2D slices very quickly to determine if blood is going up or down the neck. All you do is put a slice through the neck, then repeat it with a saturation band above, and then do it a third time with a saturation band below. And depending upon the position of your saturation band, the vessels will disappear from the image. So, for example, with a saturation band above, the jugular disappears. We also see that the right vertebral and right internal carotid turn dark. On the other hand, when we put the saturation band below, we see a very large jugular signal. But surprisingly, we see vertebral and internal carotid signals. So this is an unusual patient who has a proximal occlusion and has reverse flow in the internal carotid, which is apparently feeding the external carotids. Now, once we have our transverse images, we know where the bifurcation lies, then we can set up our sagittal slabs. And we collect 2 slabs, one over each set of bifurcations. And because we pulse them alternately, one and then the other, we can use a very long TR. We use a TR of at least 70 milliseconds. And yet we're pulsing the patient every 35 milliseconds. So this is an efficient way to collect 3D acquisition with a long repetition time. And again, the reason why we use a long repetition time is because we want the blood to flow up the neck through this large sagittal volume without being saturated. And under conditions of good inflow, the comparison between the DSA and the MRA is really quite good. Now here's that patient who had the musculoskeletal branch which reconstituted the vertebral, and there's a lot of distal saturation here, but you can see the reconstitution. Here's the patient who had reciprocal flow in the internal carotid, and this patient has the surprising finding of high intensity where the blood is leaving the base of skull, and then it becomes more and more saturated as it goes down towards the bifurcation. Well, here's a patient. Now I'm going to show you several comparisons between sagittal acquisitions and the conventional angiographic appearance. Here's an angiogram showing a large plaque right here at the proximal internal carotid, and on the sagittal 3D MRA, very good correspondence. And you can see that as long as you keep your TRs relatively long, you can have the blood flow a very long distance in the volume without being appreciably saturated. And here we have a patient with two stenoses, one of which is critical. And here we have a patient with really just a string sign on the conventional study, and the same appearance on the MR study. Again, very tight stenosis, and we see the same appearance on the MR angiogram. Now, occasionally we find that there isn't sufficient contrast on the sagittal acquisition. That's because we are using a long TR and a small flip angle, so there's not strong background suppression. In this case, on the conventional contrast study, we see this unusual long segment stenosis. It's rather irregular lobulated appearance. But when we look at the MR, we see that that detail is missing. Now, in these situations where the contrast is insufficient, we'll go ahead and do a transverse 3D acquisition. And remember, the motivation for doing that was that it improves inflow because blood travels all the way up to the area of the lesion before it enters the RF field. And so here is the transverse acquisition through that area, and now we can much better see that long segment stenosis, and it looks very much like it did on the conventional study. And in fact, we found that the 3D transverse acquisition usually gives the most faithful reproduction of what you see on a conventional angiogram. So, for example, here we see several focal stenoses, a tight stenosis of the proximal external carotid, and now on the MR we see stenoses in those same sites. And this is a study taken late in the angiogram showing that there is slow emptying of blood from this aneurysmal area of dilatation. And if I back up one now, we can see on the MR that in fact the blood comes up over this lesion and then goes around in kind of a whirlpool or an eddy type circulation. And you can often identify or guess the presence of this sort of unusual flow pattern on your MR. This is the color Doppler appearance, again showing the bulge. But on color Doppler, which admittedly doesn't have the resolution of, it's not a high resolution study, but you don't see all the fine detail that you did on the conventional or the MR study. And here's a patient who has a sudden narrowing of the carotid, and we see same appearance on MR. Now we call this often the postage stamp view, because we're just taking a tiny little postage stamp image out of the entire carotid artery. And as David was saying, one of the keys to getting a good projection is to select the smallest volume you can so that there's the smallest amount of overlapping tissue. It is advantageous to cut out these very small segments through the area that's most important for you to see. Here a patient with a web-like stenosis, and we see that again on the MR. You can see it's a little darker here because there's a little bit of turbulence after that stenosis. Well, turbulence is clearly an issue in MRA, and this lesion, unlike some of the ones I showed you previously, isn't seen at all in the MR study. In fact, we see a gap in the vessel, and this is due to turbulence. And it's still a mystery to us what types of lesions lead to turbulence and which don't. Sometimes we've had very tight stenoses with virtually no turbulence. Sometimes we have had turbulence. It appears that long segment stenoses, which are greater than 80% and usually greater than 90%, are the ones that cause turbulence. If we see a dropout in the signal over a short segment but see the vessel beyond, then that is a sign of a greater than 90% stenosis. Now, our surgeons operate at an 80% stenosis, so although we can't actually show the lumen on this image, we can at least throw it into a critical category. And here's a very tight stenosis, and not surprisingly on the MR there's a very long area of turbulence here before we start to get regular flow again. Now, if there's a total occlusion, then on the MR there'll be interruption of the vessel and nothing beyond. And that's our definition of an occluded vessel as opposed to the tightly stenotic vessel. Now, I would add one thing to the definition, and that is on 3D time of flight. Remember that you're not as sensitive to very slow flow. So if you have an extremely slow-flowing vessel beyond the stenosis, you may not see it on 3D time of flight. So then you really need to get a few 2D time of flight cuts, preferably all the way up to the carotid canal. So you can make a positive identification of the vessel in the neck and show that there's no signal in it, and therefore determine that it's truly occluded. Without doing that, I don't think that you can really say that you're looking at a tight stenosis or occlusion. And like I say, we always do the 2D for every patient. Well, here's a patient who has a stenosis, unusual in that it's on the anterior side of the internal carotid artery. And with the 2D time of flight method, notice this very long segment that's missing from the image, and that's due to turbulence. As I discussed before, with the 3D time of flight method, the turbulence issue is not quite as pronounced, and you can often see the vessel through an area of a stenosis much more faithfully on the 3D time of flight than you can on the 2D. Here's a patient again with a tight proximal stenosis. And on the 2D time of flight, we lose a lot of signal through that area. On the 3D time of flight, the signal is much more robust. Here is the sagittal acquisition of that same patient. One of the nice features of the sagittal is that you can page through the bifurcation slice by slice, and you can actually see the plaque, this gray area, and identify it, and then also see the remaining lumen. And the ability to see the native width of the vessel and the width of the result of the remaining lumen greatly helps you in determining percent diameter stenosis. Now, the native vessel, the muscular wall of the vessel, will be a dark line, and I hope that this projects well enough that you can see that dark line here on that image. And we always photograph the individual partitions through the bifurcation as a way of confirming our impression from the projection. And in fact, if there's a discrepancy, we'll always choose the interpretation from the individual partitions. David mentioned to you that there are several well-known artifacts that occur during projection. Here's a patient with two webs across the carotid, and we see these same features now on the individual partition. Now, some plaques are black, and here we see a dark plaque in the bulb. Again, this dark line is the muscular wall, and then the plaque inside of it. Other plaques are gray, and here we see a gray plaque in the proximal internal carotid. We are just now beginning to collect surgical specimens. Our surgeons now give us all of the endarterectomy specimens, and we're trying to correlate that with the appearance in the image to determine why some plaques have different signal characteristics. And I'll skip through this. This is a point that David made about always looking at individual partitions to see lesions on the front and back side of the vessel. Well, now here's a patient who seems to have a stenosis of the external carotid artery, but we don't believe that because it's a very peculiar place for a stenosis. And in fact, if you look at the individual partitions, you'll see a black field defect. This is the sign of a small flake of metal in the patient's neck. And wherever there's metal in the neck, it will greatly distort the MR angiogram. Patients who are post-op and who have surgical clips in the neck, almost without an exception, cannot be successfully imaged by MRA because you cannot have these defects in the neck. And for that reason, we encourage the surgeons not to use metal clips. Now, an interesting flow pattern well known to Doppler practitioners is that of flow separation. And just to refer to this diagram here, what happens in flow separation is that blood comes up the common carotid, and then inertia carries it forward where the blood is split into internal and external carotid, and the flow of blood leaves the wall. It separates from the posterior wall, and then the blood flows in the reciprocal direction, and so that you have kind of an eddy of blood flow, or recirculation it's sometimes called. And on color Doppler, you see this as a kind of a blue puff next to the forward-going red stream. This is a late image from a conventional study. You can see non-contrast blood coming up into the internal carotid, and you can see a stagnant pool of contrast blood in the bulb. So this is demonstration of the flow separation phenomenon on a conventional angiogram. Now, the appearance of flow separation on MRA is that the recirculating area is more dark than the mainstream because these spins are being replaced more slowly. And the clinical significance of recirculation or flow separation is that where you have this stagnant blood, this predisposes to thrombin and plaque and platelet deposition. This is often where plaques will form. This is an extremely marked case of flow separation. This is a normal carotid, and you can get some additional slices through here to prove that it is in fact normal. Fortunately, flow separation is only seen in people with large normal carotid bulbs. And patients who have narrowing of their carotids, older patients, will not show this phenomenon. We also have something similar to flow separation following a stenosis. Here we see a narrowing of the proximal internal carotid, which then opens out into its normal caliber. This is an image collected in systole, and here we see a systolic jet of blood going through the stenosis and then as a stream hitting the back wall and then filling in the reciprocal direction, so that there is less rapid replacement of blood along this posterior portion. And not surprisingly, when we form the projection, we see that it looks as if the plaque actually extends up a couple centimeters up the internal carotid. But in fact, we know that that is a flow disturbance. And if you page through the individual partitions, you'll have sufficient contrast to recognize the reverse flow. we looked at the first 50 carotids that we did, for which we had MR, X-ray, and ultrasound data for comparison. The ultrasound grading was done by the criteria of Bluth, and this is a velocity grading scheme. We graded the proximal internal carotid arteries and categorized them as normal, mild, moderate, severe, critical, and occluded. Now, where MRA and X-ray agreed, then we had data along this main axis. In other words, every moderate corresponded to a moderate. What we find is that very often MR will overestimate the degree of stenosis. So you'll always see a few points here to the right. And presumably this is due to turbulence effects. Now, for this data set, if you compare the MR to the ultrasound, you'll see that there's more scattering. And X-ray with respect to ultrasound shows a bit more scattering. Well, then we opened up the study. They were read blindly, but then we opened them up and we compared them side by side to decide which one made the mistake. In one case, X-ray made a bad error because neither of the projections really opened up the vessel sufficiently to show the stenosis. In MR, there were 3 important mistakes. One was early in our study. It was done with insufficient resolution. The second had excessive patient motion. And in a third case, there was a ulcer present, which we had interpreted as being a portion of the main channel. In ultrasound, there were 7 errors of more than 1 grade, and generally that was due to unrecognized velocity artifacts. In other words, tandem lesion, for example, that may dampen the waveform, or a contralateral lesion which would elevate the velocities. In 2 cases, the bifurcation was too high in the neck to properly assess. Now, the correlation coefficient between MR and X-ray for internal carotid arteries was 0.94, and that was higher than the other comparisons. So, of the 3 modalities, MR and X-ray were the most similar in the types of information that they provided. Well, what is 0.94? How good is that? We took 48 X-rays of good quality and had them read by 4 individuals, and then did pairwise correlations between those readers and found coefficients that varied between 0.9 and 0.96. In other words, there was at least as much difference of opinion between readers as there was between modalities. So there comes a point where we won't, because of the differences in individuals, we won't be able to measure lesser or greater correlation. Well, here is an example of an exam missed by ultrasound. In this case, they read what they had interpreted as an internal carotid waveform, but in fact it was in the external carotid artery. And in fact, on the conventional angiogram, we can see that the stenosis truly is in the external carotid. And here's a patient which actually wasn't missed, but it just shows a type of artifact to watch out for, and that is that when the blood turns a corner in Doppler ultrasound, you may have spectral broadening. And if you don't recognize this as being the etiology, you might possibly mistake this for a stenosis. Here is a ulceration seen on MRA, but it was below the resolution of color Doppler. Now, maybe with other types of Doppler, it could have been identified. Here's a patient who has a sudden turn in the vessel and an ulceration, both. And here we see spectral broadening, and we don't recognize the ulcer on Doppler. Well, what about the issue of differentiating critical stenosis and complete occlusion? Obviously, this is surgically very important. And what we've discovered is that unless you do 2D time of flight up to the base of skull, then you really can't differentiate these two. Sometimes you may misidentify a pharyngeal branch as being the internal carotid artery and say that it's patent when in fact it's absent. There are other things that you can do besides 2D time of flight. One is to give gadolinium, and as long as a vessel is patent, it will be bright if you give gadolinium. As long as the gadolinium can get into that vessel. Some people are using phase contrast for this differentiation. So for example, here's a patient with complete occlusion. We go up into the base of skull, and there's nothing entering the carotid canal. So this is how we define then complete occlusion. Once again, complete occlusion, and there's nothing in the base of skull. Well, the most common reasons for MRA failure, and it's important to note that there will be a significant fraction of patients, maybe at least 10% will fail MRA. Claustrophobia, obviously this is an issue for all types of MR. Patients who aren't able to hold still, and patient motion really will very quickly deteriorate the MRA quality. And finally, the presence of any sort of metal, surgical clips, or even just flakes from surgical instruments. Well, just kind of a roundup of some of the advantages over Doppler ultrasound. With MR, we can go from the arch all the way up to the siphon. We can follow tortuous vessels. There's no problem with looking at high bifurcations. We're not obscured by calcification. The study can be performed immediately post-op, even if a dressing is present over the neck. And the study is, I won't say it's not operator dependent, but it certainly is less operator dependent in that the images can be read retrospectively, whereas in ultrasound, the operator really has to identify the lesion while the patient is in the room. It's very difficult to go back and reinterpret a Doppler study that wasn't done properly. Obviously, Doppler is more accessible and less expensive. Well, carotid origins is clearly an area that we're interested in, and I showed you some 3D sequential ways of doing that. We have devised a coil that goes down low enough in the neck so that we can actually collect with a higher resolution coil the origins from the arch. Here's a 3D transverse acquisition. And if you're going to be doing 3D transverse, it's very important to put the leading edge of your slab right up close to the origins. You don't want to put it down low through the transverse arch. And the reason for that is that blood is stopped during diastole, and it will very quickly saturate during that period, and you'll lose all your contrast. So you want to just kind of tickle the arch with your RF field. Don't get too greedy. Here's a direct coronal acquisition using that low-lying coil. Here's a patient with a subclavian stenosis and who actually had a Steele phenomenon. And here we see that same stenosis on MR. Patient with an aneurysm of the right brachiocephalic artery. And here we see it in the sagittal view. This patient comes back every 6 months to be re-examined, and we've looked at him now 4 times just to assess how quickly this aneurysm is growing. Now, a problem with imaging at this level is that sometimes the vessel is swamped out by mediastinal fat. In that case, I would look at individual partitions. And if you've acquired the data transversely, so you can't look at the individual partitions, then I would use what's called multiplanar reconstruction. I know that many of you have these workstations that allow you to reformat slices in any orientation. If you reformat a slice through that vessel, you'll suddenly get all the contrast you need. Vertebrals are still a problem. Sometimes we catch the vertebral very well. Often we don't. The issue is resolution. And now that manufacturers are coming out with 512 matrix, and I know that they're even working on 1024 matrix MRA, we'll have the resolution that we'll be able to see these vessels. Siphons, David explained to you a sequence that he wrote to look at the siphons, and this is using a conventional sequence. This is with David's sequence, and these very short echo time sequences will allow us to see areas in which blood is changing direction and may be turbulent. Here's a patient with irregularity of the infraclinoid portion of the carotid, and if we look at an individual partition from that MR data set, we can actually see this trapezoidal gray plaque. That is, in fact, the plaque in this patient's siphon. Well, let me just wrap it up here. What then is the role of carotid MRA? And I think that you could devise, depending upon what you're trying to achieve and depending upon the relationship you have with your surgeons, you could conceivably think of two different roles. One would be a screening exam. And in this case, one would probably just do one set, either transverse 2D or transverse 3D through the bifurcation. And if that was normal, then your workup would be finished. If it was abnormal, you might have to bring the patient back for a more complete view, or else send them on for a conventional angiogram. And you'd probably do this in conjunction with a T2-weighted image of the brain. Alternatively, you can think of MR as being a dedicated or definitive exam, and in that case you do multiple acquisitions through the bifurcation, through the origin, through the siphon, with the idea that when you're done, that patient would go directly to the operating room without the need for conventional angiography. Well, as a screening exam, we're competing primarily with ultrasound, and this is difficult because I'm not sure that there are enough magnets in the world to do all the carotids that exist. Furthermore, it's certainly more expensive and less accessible than ultrasound. And some people really don't like to be inside the magnet. They'd much rather have an ultrasound exam. On the other hand, as a definitive exam, we're competing primarily with X-ray. And I think this is really what's going to profit the patient most, because there won't be all the risks involved with conventional angiography. Now, everyone asks me, do your surgeons operate on the basis of MRA alone? And I can tell you that after working with them for a long time, they have started to do that. This is a patient who came in last Tuesday and had a crescendo TIA, and went up to Doppler ultrasound first, and the machine promptly broke down as he arrived. So then was brought down to MR. We identified severe stenosis on one side and a critical stenosis on the other. And here you can see that there's very little flow in the distal internal carotid. It's almost completely saturated by the time it reaches the head. And that patient, that was about 8 o'clock at night, and by 9 o'clock they were already prepping him for the operating room. So I'm quite certain that we will see MRA as a pre-surgical imaging tool. Thank you.